Thanks so much. Thanks so much again to the QoLA group for arranging this. I think this has been an unprecedented 6 months for everyone, and I know with September upon us, there's a lot of tough decisions that have to be made for families. And the goal of this presentation is just to provide a bit of perspective from what we know so far around the COVID-related data as it pertains to children. And you know, that is limited in terms of the populations that have been fully studied, recognizing that, you know, most kids have been at home, whether they're healthy kids or more medically complex kids, they've been at home, and so there is limited data. There's a lot of regions that, despite that, have had community transmissions occur, and so we do have, you know, good oncology, dialysis population data, so we can speak to that. Again, as Cindy said, I've really done this talk on Tuesday, so if anyone feels that it's redundant, like, feel free to step off the line, come back, whatever's helpful for you. And I also just want to make it clear that this isn't sort of my perspective on COVID. This has been in consultation and discussion with our entire infectious diseases division and our medical director of infection prevention and control for HHS as well. And again, most of what this content is what was used to guide the Sick Kids document that you may have seen, that McMaster Children's Hospital endorsed, and, you know, our group has also reviewed. So this is, you know, interpretation of the data we have to date for children, and as much as we have for medically complex children as well. So it may seem in contrast to what you're seeing in lay media, because I think there's a lot of hype, because we live next to the US, where they're suffering from a very different pandemic management system compared to us. And so I think, you know, community prevalence is really important to guide some of these decisions. And, you know, we've had things under control for some time in Hamilton. We didn't actually have that peak, that huge surge we were all very worried about in March and April. And so, you know, a lot of our guidance has been to sort of step back and reopen where it makes sense and where it's safe to do so. And again, it's guided by our local epidemiology. So with that, I just wanted to sort of preface this conversation with that, and then we can jump in. So what I plan to go over with you is understand numbers and how much of an impact has COVID had on children in Canada to date. Again, to put it in perspective to what you might be seeing out of the media hype, a lot of which is coming from the US. We'll talk about why kids, you know, in general need to go back to school, and the importance and the benefits of, you know, accessing those resources that we've had to, you know, shut down to a large extent because of the pandemic, and, you know, reopening in a safe way, so that kids can grow and develop, which is really the most important consideration for kids, because there's been so much collateral damage in terms of the implications of the pandemic and the shutdown for kids in general and their health. So we'll talk about, is school a high risk for children? What do we know about how susceptible children are to infection and how transmissible they are to each other in a school type context? And compare that to adults, and why we see such high numbers in adults, potentially because they're more susceptible and transmit it much more easier. And then we'll talk about, you know, what we know and what guidance documents have come out about which children should not be going back to school, and that is a very small subset. And then what we can do to protect our medically fragile children, but still offer meaningful growth and development. And then in discussion, we pulled out the aerosol generating medical procedure discussions from this talk, because we didn't think it was too relevant. So we'll skip over that side. So just to start off, in terms of case numbers to date here in Canada, as opposed to the US, which has in the millions, Canada has 120,000 overall cases in the past 6 months. How many of those are children? Only 8.3% of all those 120,000 cases are children, so that makes up about 9,900 cases. Now, how many of those pediatric infections needed to get admitted to hospital? Only 1.2% of all hospitalizations were of children, and that's only 138 of the 9,900 pediatric infections needed to get admitted. And it's also important to note that many of those admissions to hospital were actually for reasons other than COVID, but that because they were admitted and diagnosed with COVID, it gets counted in this case count. So it's not that the COVID was the reason for admission. And I can speak to, you know, the handful of cases we've had at MCH. The vast majority weren't needing admission for COVID. They were needing admission for all the other reasons that kids sometimes need admission to hospital. that's sort of I think an important number to note around, you know, how kids aren't making up a big part of this pandemic. Now, in terms of how many of our kids are needing ICU admission, so again, it's accounted, children have accounted for 1.2% of all ICU admissions across the country, but that only works out to 27 kids. And the same goes for why those kids needed ICU admission, not necessarily because of COVID, but they were in ICU for other reasons such as, you know, cancer treatments and whatnot, and ended up in ICU and not necessarily related to COVID. And I know nobody really wants to talk about death, and it's just, I don't want to spend a lot of time talking about case fatality, but just of note, really there was one pediatric patient that died with COVID, and it wasn't actually from COVID. That case was in Toronto, and again, it was actually other reasons that they passed that wasn't actually specific to COVID as the cause of death. So noting, you know, the small numbers that we're talking about, this is a slide from the CDC that talks about, you know, how serious is COVID for children. And, you know, we're hearing about all these adults that are needing ICU admission. It's not even really the healthy adult age group. It's these, you know, older than really 60, 70 age that are very high risk needing hospitalization. And if you actually want to talk about how much fold lower risk are children, you know, young children are actually multifold lower risk when you compare them to healthy young adults, 18 to 29-year-olds. And of course, you know, there's factors that increase our risk, being in crowded situations, close physical contact, enclosed spaces, and durations of exposure. And this is why we saw like long-term care facility outbreaks in terms of the elderly populations. And that's why certain areas had high hospital admissions, because it was elderly comorbid patients that we struggled most with in Canada. Now, obviously, there's risk mitigation strategies that can further reduce our risk and our children's risk, and that includes wearing a mask, social distancing, hand hygiene, and cleaning and disinfection. We'll talk more about that in a school context. So overall, if we want to talk about numbers, kids make up, you know, if you look country to country, anywhere from 1 to 10% of all COVID cases. And, you know, I have to recognize the limitations of this data, that this is recognizing that kids were in lockdown with their parents and not going to the grocery store like their parents were, and so their community exposures were lower. So we have to acknowledge that the exposure risk was lower, but regardless, even in areas where there was high community rates of transmission, they're still only maxing out at 10% of cases being related to children who had exposures in the community. And when we talk about what type of infection these kids get, it's very mild. Many children are likely asymptomatic. So even if the case numbers are higher because kids are just not being detected, it's because the infections are so mild. And so we have to recognize the caveats to all of this data, that kids were in lockdown, and that because there was asymptomatic cases, the numbers may be slightly higher, but that's also still reassuring because it didn't result in higher hospitalizations or significant, you know, mortality rates. And overall, as you've seen, extremely rare to have death or ICU admission in pediatric age infection, though recognizing, you know, there are certain higher risk groups, and that's the groups that we're speaking to here today with other underlying conditions. So what about if we want to just think about other viral infections that we see year to year, something like influenza? And so I think this is a really important slide to recognize that influenza is actually a much bigger problem for kids than what we've seen from COVID so far. So kids are actually, you know, much higher risk of, you know, severe infection, potentially even hospital admission or death, multifold risk for influenza, whereas adults really are the ones that are struggling from COVID, and influenza doesn't have as much of an impact on them. And I think it's important to think about that, because year to year we send our kids to school despite influenza. I do recognize there's a vaccine to influenza, but as we also know, influenza vaccine sometimes isn't a good match here, right? Because we have to change that vaccine every year. We do our best to guess which strain is going to hit us, but many years our vaccine has only been sort of 50% effective based on the circulating strain that we get. But we still send our kids, recognizing the importance and the benefits of school and the other resources that we get through school. What about parents? So I think, you know, another big question that we're getting is, well, okay, fine, the kids will be fine, but what about their parents? What, how high risk is, you know, the adult of childbearing age? And again, you can see the vast majority of cases and deaths are much higher in the elderly range, and not really the parent age range that we're talking about. And also, I know I don't want to focus on death. That really wasn't the point, but this is just, you know, the data that we have to date, and putting it into perspective of the other risks we take every day. Like we've talked about the risks in flu season that we take and we accept every year and send our kids to school. If we want to talk about risks of death from other things we engage in every day, like going in a car, COVID death in a young person, even up to 30, is about the same risk of dying in a car accident. Same with accidental injuries, you know, the accidents that happen that is a high risk of issues for young children needing admission or to hospital is actually much higher, threefold higher compared to the risk of COVID in a young, healthy person. Again, young and healthy being the caveat, and I understand that we're talking about a different population. So in terms of COVID cases in schools, we have to recognize again that if we see an uptick in cases in the community, that may require reconsideration of having our schools open to everyone or potentially open to the more fragile. So again, we have to do our best to keep COVID at bay in the community in order for our schools to remain open and remain open for everyone. And so, of course, all the advice that even our Sick Kids document speaks to is keeping COVID in control in the community is essential in order to keep schools open. And the other reality that we have to speak to is we have to continue to control COVID while still and putting lockdown measures that make sense in place, but still minimizing the harms of all the lockdown measures that we've put in place. And I had a slide on like how many kids are not getting vaccinated because of lockdown, how many kids aren't getting their primary care, how many kids are delaying coming to hospital because they're scared of COVID, and then we're getting kids in much more severe situations that we could have prevented hospital admission for their other medical problems because people are so scared of COVID. So COVID and its lockdown has resulted in actually probably more harms to children, not directly because of COVID, but because of all the measures and the fear that's out there right now. So shifting gears a little bit, talking about who are the populations that we really need to worry about our increased risk of severe COVID. Again, this is adult data, but even among adults who we know are higher risk, asthma increases the risk 1.5-fold, hypertension, obesity, diabetes, kidney disease are all conditions that we know increase baseline risk. And we know if you have more of those conditions, it increases your risk further. But I think we have to think about that still in the context of what the baseline risk is in children. And as we've said, if there's a 0.01% risk of death, even if you multiply that by 5-fold, that's still a very low number, well below what we tolerate for influenza, even in our complex children. And so if we talk about 900 cases of COVID in children, 138 admissions, even if you sort of multiply that by a 5-fold incremental risk in certain kids, it's still much lower than what we tolerate for other viral processes. Recognizing that, you know, those with a immune suppressed system and underlying cardiac and lung disease also sort of fit in a higher risk category. But again, even if you multiply it by multifold, it's not actually that much of a true risk when we compare it to the other risks we take day to day and year to year with other viral infections we know we expose our kids to because we know there's benefits to being in school. And then also I wanted to speak briefly to the data that we know about racial and ethnic minorities also being somewhat at higher risk of severe disease. This seems to, when we look at the data, likely be mostly related to socioeconomic factors because their increased exposure due to occupational exposures or their crowding in homes or other comorbid conditions, and not necessarily sort of a biologic link and more sort of an environmental link as to why we've seen more severe infection. So that being said, what is the general consensus from, you know, pediatricians, infectious diseases specialists across the board? The risks of direct infection and transmission of COVID to children and youth and the school staff and the community are something we have to be mindful of. We have to mitigate the risk as much as we can, but the harms of school closure are definitely much outweigh the risks that we're talking about on the other side. So we know that the physical health, development, mental health, learning, social, emotional skills, safety, and nutrition have been a huge detriment since we've had to close down schools to children. And so this is why the Canadian Pediatric Society, the American Academy of Pediatrics, has spoken to the importance of really ensuring all kids can get back in school and safely get back in school. So we'll talk a little bit about, okay, fine, if everybody's saying we should go back to school, what is actually going to be the risk to kids? How susceptible are they to infection? How likely is it that some child who maybe doesn't mask effectively, maybe their community isn't following, their exposure guidelines appropriately, how likely are they going to transmit to my vulnerable child in school? And then what do we know from other jurisdictions on schools that have been able to reopen, and how the clusters have landed? So if we talk about how susceptible are kids to infection if they're exposed, so first of all, that there's a case in the classroom and a child is exposed. Our best data around that is based on household contact tracing. And that's because in a household, you really know that everyone, the kid and the adult, are all exposed pretty much to the same degree because they're all living in the same house. Whereas if you talk about a community cluster like the nail salon in Kingston, or let's say another level of exposure in like a grocery store, you don't know what degree of exposure has happened. So if we want to focus on household contact tracing studies being the best estimate to compare how likely an adult is to get infection compared to a pediatric patient if they're exposed to someone with COVID, the odds ratio, or the fold risk of an infected contact transmitting to a child was essentially like probably 2 to 3 fold less, or an odds ratio of 0.41, so half the risk in a child getting it compared to an adult getting it from the same degree of exposure. So they're half as likely to acquire infection from an asymptomatic case, and they seem to be less susceptible even compared to sort of another adult family member in the same home. What about if there's a kid and the likelihood they're going to transmit to another kid? So like the classroom scenario, or let's say your healthy sibling that might be going to school and coming back to the home, what's the likelihood they might transmit if they do pick it up and possibly are asymptomatic? So we know, again, from the household clusters of cases that children really are rarely the first case in the home to get it and then transmit it to others. So only less than 10% of the time when we look at these clusters of cases, is it the child that's the one that brought it into the home? And even if you sort of say, well, what if the child was asymptomatic, and so really we can't rely on their symptom onset to say that they were the index case. Even if you exclude them and you make the assumption the child was the index case, it's still only sort of a fifth of cases where that explains how COVID gets into the home. And furthermore, there was also clusters where the child clearly traveled. So there was one scenario where a child traveled from one area in China to Wuhan, so they were really likely the index case. If you take those out, again, it's only sort of 10% of the time is it likely that the child is going to bring it into the home. And when we compare that to other viruses like influenza, children are much more likely to be the index case that's susceptible to infection in the community and then brings it home and causes transmission in the home. So again, we tolerate certain risks with other viruses, and it seems like the risks are actually much lower in children. So it's really unlikely that the sibling or the child's going to bring it into the home from their school. So why are they less likely to be the index case? Because what we know from early data is that they're actually less susceptible to infection. Children have less of the receptors that the virus needs to use to get into the body in their upper respiratory tract compared to adults. And they also appear to be less infectious. So let's talk a little bit about that. Now, this is very early data, and it's really very minimal studies, but they seem to also have less of a viral load. So this was one study, for example, where children actually had a 4-fold lower viral load to young healthy adults, and as you get older, the viral load does increase. So older age children, their viral load also increases, but the very young children, less than 10, seem to have less of a viral load. Now, this is very early data, and there's very little studies on this so far. So this may change as we get more data. But there is some data to suggest that there's lower viral loads. It also appears that children are less symptomatic, as we've said already, which also typically translates to a lower viral load. We also know that asymptomatic children, when you just look at kids that never had any symptoms, but they definitely had COVID when they were tested, they also clear their virus load very faster than adults do, 12 days compared to 16 days in those that were symptomatic. But adults we've had that shed it for weeks and weeks. So kids do seem to recover and clear it very quickly, so therefore are likely less infectious to others. As we've said already, severe infection typically has a higher viral load, and we also know that kids don't typically get severe infection, so also another piece that we can use to say they're probably less infectious to others. And as we know, they're less infectious to others just because their case numbers are so much lower. We also know that adults seem to transmit to each other much more easily than do kids. to each other. And so kids really don't share this virus well. So even if there was a case in a kid's classroom, they don't seem to be able to transmit it to each other as well as adults would. And adults seem to be bringing it into the home rather than kids. And kids likely don't shed it as much and therefore are less likely to infect their adults in their home as well. So overall, kids are sort of the lowest risk category to get it, to get severe infection from it, to transmit it to others, or to be susceptible to it in the first place. So that was sort of the take-home points. And even in children with comorbidities, they seem to still have a lower incremental increase in risk compared to adults with the same comorbidities. So what about school-related data? What can we understand from other regions that have opened schools? And there are many, as you know, European countries, Asian countries that have been able to open and open safely. And I know you're hearing in the media about all the clusters, Israel, for example, Chile, where there was transmission. Again, that's because what gets published, what gets written about is the clusters, the outbreaks, and the many other schools that are chugging along just fine. Nobody's writing about those situations. And what we know from now lots of separate cohorts of data is that young children do not seem to be a major source of transmission in the school. And there's now a good volume of studies where we can say there's a moderate level of evidence. I cannot say that about the viral load data. Clusters, when you trace them back to communities and home settings, again, as we've said already, moderate and consistent data that it's the adults that were the index cases, it's not the kids bringing it in, it's not the kids transmitting to each other. And we know that as age increases, likely viral load increases and transmission increases. So like high schoolers are likely higher risk than younger elementary school age children to transmit to each other or to even pick it up. And again, all of this is to say that we only have known this virus for 6 months. It's not the same as what we've known for other viruses. So I do acknowledge the limitations to this data. So just to summarize again, children don't seem to be a major source of infection to others or each other. Clusters or outbreaks in schools were typically actually related to issues about high community transmission happening and potentially kids getting it in the community and then sharing it in school rather than it starts in the school and then spreads to the community. And most of the outbreaks, like for example, Israel, was a heat wave that hit. They had big high class sizes of up to 40. They were unable to mask. And so there was lots of other factors that they were not able to mitigate the risk and why we heard about the big media hype around that big school-related outbreak. As age increases, we know transmission risk increases. We have to acknowledge that, high school being a higher risk scenario than elementary school. And many open schools really are doing just fine and aren't getting reported about because that's not what makes the media. So summary, overall, the risk of kids in schools are low. They make up a fraction of cases thus far in the pandemic. Their infections are mild. They'll be interacting for the most part with their peer age groups. And so they're not really transmitting as well to each other because they're less susceptible and less transmittable. And then again, back to their immediate families. So they're not having a ton of other community exposures as well. They seem to be less contagious, especially less than 10-year-olds, and they seem to be less susceptible based on the data we've talked about already. So what do we also know are ways that we can keep things under control in schools. So this is taken from the Sick Kids document. It is the hierarchy of controls that we're all advocating for, implementing them as safely and as effectively and as we can with the cost limitations to make schools as safe as they can be for all children, especially our medically fragile children. And so this includes things like PPE, administrative controls where we can doing classes outside, making sure we have hand hygiene breaks, making sure we teach kids how to cough and sneeze appropriately and safely if they need to, and that we have good and important screening policies in place where kids that are sick cannot come into school and staff that are sick should not be coming into school, that being a really important part of prevention. And then environmental cleaning, though we'll talk a little bit about how high risk are inanimate objects or fomites, because I know that's been a question. Again, ventilation being a consideration in hospital settings, we have higher airflow coming in from outside, and schools need to do what they can to optimize ventilation and airflow, physical distancing, and cohorting so that we reduce the numbers of exposures that happen, and then excluding kids from school that are unwell before we know what they have. So that being the most important strategy. So that being said, just a key quote that I think we all have to know is that in this document, the majority of children with underlying medical conditions should be able to safely attend school provided that these enhanced safety measures are in place. And that was sort of the overall global recommendation, so even our medically fragile children. So what does the Ministry of Education plan look like so far? Again, we all know things are changing day to day, but it does appear that we're talking about in-person delivery for the younger age group, and that does make sense based on what we understand about the younger age group and the importance of that group of getting an education and picking up early educational needs, and again, minimizing their cohorts of exposure. For secondary school, as you know, it's a school-based approach based on the urbanness and the community prevalence, where a hybrid model is being suggested for where there's higher risk of community prevalence, with cohorts of around 15. All other areas with high schools can still proceed with conventional 5-day in school. But Hamilton falls into sort of that higher risk urban category. Grades 4 to 12 are being advocated to wear masks indoors. And there's a lot of back and forth about whether people think kids can mask. And I think we've learned a lot so far about how with appropriate education, even younger kids can probably do it. But we didn't think it was reasonable even in the Sick Kids document to sort of force that on young kids that may not be able to. Again, knowing what we know about their infectiousness. So the safety measures planned, as you know, all the school staff will be wearing PPE. They're going to stagger the breaks so that there isn't high traffic in the hallways. And specialized teachers, of course, will need to go into classrooms. So we're, again, trying to minimize the number of exposures, but we still need to accommodate kids that have special needs. And those with an IEP, of course, may need to leave the classroom and go to a smaller setting. And again, that should still be safe to do so, given the other control measures in place, with the goal of still limiting as much as we can and cohorting as much as we can, and the importance of self-screening and keeping kids or staff that are sick outside of the school. As you know, there's a talk about using bigger spaces, using gyms or class sizes that can be accommodated so that you can get that spacing in, adapting environments as best we can, optimizing one-way traffic, distancing, and playground capacities, and making sure that hand sanitizer is available and accessible, schedulized hand hygiene breaks, and of course the importance of mental health supports, because kids have really been struggling throughout this pandemic, and school needs to be a safe space and a place to accommodate their needs, including their mental health. And the important part of the Ministry of Education plan is to make sure that there's the capacity and the ability for medically fragile students to still attend school if that's what their family desires, and as long as school is safe to do so. And that's supposed to be happening in consultation with public health. And we've also been involved in helping with some of those decision-making discussions. So what is the general statements that have come out so far about truly immune compromised children? So that means children on immunosuppressive treatment, such as chemotherapy, high dose steroids, monoclonal antibodies, like true immune suppression, not just medically fragile, where their immune systems aren't exactly the same as a healthy child, but not to the extent where we're talking about the immune compromised situation. So only children who previous to COVID, so prior to the pandemic, were advised not to go to school. So even that is a very small subpopulation of oncologic populations, induction chemotherapy, AML, high-risk cancers, are being told or advised not to go to school. All other children on immunosuppressive treatment are still being advised to go to school, despite being on immunosuppressive treatment, because of the safety precautions being put in place. And for patients that have severe underlying comorbidities, such as underlying lung disease, it's meant to be a conversation. But again, the discussion of, with the appropriate measures in place, we should feel safe to allow these medical fragile children to still attend school because of the benefits outweighing the risks. And again, siblings of medically fragile children, again, should still be able to attend school, and it's still a safe scenario for the medically fragile child at home. So that's again by the Pediatric Oncology Group of Ontario. So, and I also wanted to speak to reassuring data, because I know one of the comments that we've heard is that, well, yeah, but all our kids have been sheltering at home. We haven't had them out and about, so how can you say they're not at risk? What we do know is that there are oncology cohorts of children. There's dialysis cohorts of children. So people who are truly immune suppressed in different ways, who have had to be going in and out of hospitals where there's high risk of exposure to infections. And when we look at the outcomes of COVID infection in those children, again, very reassuring. It's sort of not any more severe than other viral infections we see in children. And so even children that have been out and about in the community, we can say we have reassuring data on them, where even if they do acquire infection, they still recover from it, not the same way a fragile adult has not been when we talk about the very elderly comorbid population. Similarly, we talk about pregnant women being somewhat immune suppressed as well, because their body has to not fight the foreign body, the fetus within. And when we look at pregnant women that have had infection, and pregnant women with influenza are also a high-risk group. They do much worse with influenza when we compare the pregnant women that have acquired COVID, and as well their newborns that have been watched to see if they will acquire infection. And the vast majority of newborns have not acquired infection from their mom, either in utero or even postnatally. And the pregnant women have done very well, better than what we see with influenza and other viral infections. So we have data on other vulnerable populations. It's actually very reassuring. And this is just, again, to make the comparison with influenza, because again, that's a risk we all accept every year. We still send our kids to school, and we know that influenza causes severe disease for our children of high medical risk conditions. And yes, we have a vaccine, but it's not, year to year, it's not always as effective as it could be. And in some situations, some vulnerable children don't get influenza vaccine for various reasons. And we still are able to protect them and let them attend school. So just to make the point again, that COVID seems to be a severe disease in elderly adults, whereas influenza is a severe disease for all ages, especially extremes of age, young children with comorbid conditions. But again, we still let our kids go to school every flu season. So just speaking to the QoLA families and the importance of being able to access the resources that are available to you in school, and that being part of the collateral damage and the concerns that we have, where if people aren't able to go to school and access some of the resources that are there, whether it's speech language or other resources, are we really thinking about the best interest overall of our children? And it's not to delay or to allay concerns entirely. We know that these are very fragile children, but we have to consider the quality of life of our children, and give them the opportunities to learn, grow, socialize, and develop in safe environments. And we have to foster their potential whenever we can, when we have the resources to make sure the environments we're putting them are safe. So how can we prevent the spread in homes with potentially higher risk family members? So when kids are coming back from school, making sure that they're washing their hands. We want to ask kids to try and get them to mask effectively when they're in public spaces and they can't distance. We want to minimize the number of external exposures where we can, and the size of the bubble that we're in. Fomites has been a question, and I have a separate slide on that, but are actually considered lower risk. We have not seen a lot of transmission that we can say is definitively from fomites. A good general recommendation is things like the backpack, the stuff that lots of kids might be handling in a school day. Probably better not to have that sitting on the kitchen table where we're all going to eat. So just common sense stuff you'd probably do anyhow, because you're worried about other viruses and bacteria as well. But I'll speak to the fomite risk, because I know people have been very worried about that in the next slide. And then, where possible, physically distance or mask if children are in close proximity to comorbid, elderly, high-risk family members as well, is something that we can consider offering as well as a risk mitigation strategy. In the setting of a medically complex sibling, we must also do our best to support and nurture the growth of the healthy sibling as well, rather than stigmatize them as the source of infection to others because they went to school and now they're putting everyone at risk. So I think it's important to just balance how we talk about this with our kids as well. So I just wanted to spend a little bit of time on fomites or inanimate objects and really talk about what do we know about transmission through them. So you may have seen lay media has talked a lot about COVID has survived on materials up to 10 days and things like that. And this material, it survives more on compared to that material. So these studies are typically done in lab environments where they use very large inoculum of viral particles that is really well above what you would see in a booger or a snot or a cough on you. It's well above the amount of viral particles. And so, yeah, probably it'll survive much longer if you put a lot more of virus on it than what would possibly happen in a normal physiologic environment. And so it's not really safe to say that, wow, it's going to survive for 10 days for sure on that kid's backpack. And in fact, most of this data that they've looked at is just looking for RNA of the virus, which can just be dead virus. It's not culture proven positive replicating virus. And we know from HIV, Hep B, where kids needle stick themselves in the community, maybe there's IV drug use and there's a community member that leaves a needle outside. Viruses don't survive long on materials and don't survive and replicate and are infectious to others for the most part. So even when kids needle stick themselves in from blood, from high-risk substances, again, the likelihood they get infected is very low. So I just want to re-emphasize what we know about viruses in general and just de-emphasize what's gotten out there about how high risk are inanimate objects. Because they're not likely to survive. And we also look at human coronaviruses, so other similar viruses to COVID, and they really have only been able to survive for a couple hours on multiple different surfaces because it does dry up very quickly. And when you try and culture it, you typically can't culture it out and grow it out. And just for what it's worth, like we work in hospitals, we work with COVID patients, and we do wear gowns when we go into a COVID positive room because we're sitting right next to, within 2 meters of a patient. They're coughing directly on us. We sit down on their bedsides, we spend time in their environments, which is very different than, the transient degree of exposure that you might have in a school classroom. That patient's living in that bed, in that room, day in, day out, 24/7, is coughing in that environment. Very different than what we're talking about for schools. So yeah, we do wear a gown. Do we all shower when we come home from work? The vast majority of doctors that are seeing COVID patients aren't doing that. You may see, like there was early in the pandemic, people were sort of changing in their garages and, wanting to shower. I think a lot of that fear has been allayed the more we've learned about this virus. So even healthcare workers aren't, forced to shower before they leave the hospital or when they get home. And again, when we think about how healthcare workers have gotten infected, it's not from their hospital bag that they're bringing home and leaving in their doorway. In fact, most of healthcare workers that have gotten infection hasn't really been from the hospital. It's been from their community exposures. It's when the doctors are going to the grocery store and they're picking it up the same way another community member might. So all that to say that I think we've now really rethought a lot of the hype that was happening at the beginning of the pandemic. And even in the hospital, doctors aren't wearing scrubs the way that people were at the beginning of the pandemic because they were so scared of what they were bringing home on their clothes. So just wanted to sort of de-emphasize a lot of the pandemonium that's been happening around inanimate objects being a source of infection. So in conclusion, medically complex children are at slightly higher risk if they acquire COVID in the community, like all respiratory infections. Nonetheless, this incremental increase in risk is still small and very much outweighed by the benefits of being in school. Children less than 10, we actually have good data now to support that they're not highly susceptible or transmitting infection. The benefits of school for almost all children will outweigh these risks, even medically complex children, even immunosuppressed children where resources are limited in the homes, and importance of caregiver needs and the burnout risk of you as parents that have been with the complex children and managing on your own for 6 months. We have to consider the quality of life of the child and the family as a whole. And opening of schools can be done safely. We've seen it now in many jurisdictions across the globe, and we can still protect our most vulnerable, including our high-risk children. Whatever decision you make, of course, at the end of the day, you have to feel comfortable with it. And we hope that this at least helps to ease some of the doubts that you might have about the safety and benefits of returning to school, even in comorbid children, and just puts it a little bit into perspective, because we know what's out there in terms of what you might be reading is a lot of hype, and it's not really relevant for us in our epidemiology locally. So that was sort of the key content we were hoping to cover, but I think that was it from our perspective around slides.